Subscribe now and press the bell icon. Never miss an update.
Interactive session on spleen and its diseases. Before starting to disease of the spleen, first we recapitulate the anatomy of the spleen. Spleen is developed from mesenchymal cells along the left side of the dorsal mesogastrium. The weight of the spleen variable from 75 to 150 gram in an adult. It is situated posteriorly between the fundus of the stomach and the diaphragm in the line of 9 to 11 rib. The spleen is in contact with the adrenal gland, upper pole of the kidney, left kidney, and the pancreas and the splenic flexure of the colon. The structure which lies surrounding the spleen, that all are related with the surface of the spleen. The peritoneum covers the spleen whole except in the hilum. That hilum, except the hilum, whole spleen is covered in the peritoneum. The superior border of the spleen contains the notches, which indicates that the spleen has lobulated in origin. So there is some notch there. The spleen is supported by various ligaments like gastrosplenic ligaments. That means they are attached with the stomach, which is called the gastrosplenic, lienorenal, and lienophrenicocholic ligament. That means structure with the pancreas with the spleen, pancreas with the colon, pancreas with the stomach, pancreas with the diaphragm, pancreas with the kidney. All these organs are attached by these ligaments, supported by various ligaments like gastrosplenic ligament, lienorenal ligament, lienophrenic ligament, and phrenicocholic ligament. The hilum transmits the splenic vessels, nerves, and lymphatics. For that reason, the hilum is devoid of peritoneum. Because if it is covered with the peritoneum, in that case, it is not possible to pass all the vessels and nerves through it to supply the spleen. Histologically, spleen consists of the red pulp and white pulp. So, blood supply of the spleen. The blood supply of the spleen is supplied by the splenic artery. This is the splenic artery. It is a big artery and tortuous, which is a branch of the celiac trunk. From the celiac trunk, the splenic artery is transversely run along the superior border of the pancreas, and ultimately it enters through the hilum to the spleen by dividing into various branches. The branches having a very important role to preserve the kidney during surgery. If you divide that branch, so that divide and ligate it, so that branch, the supplied area is only infarcted, and that area you can remove, particularly in case of liver splenic injury. So lobular branch or segmental branch, if you divide here, ligate it, if the injury, only that vessels, if you ligate it, so you can save the spleen, part of the spleen is saved, only divide the lacerated segment downwards. So for that reason, the anatomical distribution of the vessels must be known everywhere. And the vein is drained, which is called the splenic vein. So from the splenic artery near the hilum, the short gastric vessels arises and supply the greater curvature of the stomach near the fundus. For that reason, that short gastric vessels is required to divide, cut, ligate and cut, or by diathermy, you can divide it to disconnect the spleen from the stomach. And another branch which is not shown here, there is a right gastroepiploic artery, which is also supplied from the splenic artery from above. The vein also drained in the short gastric vein and the left gastroepiploic vein that drains the splenic vein. So this is the main arterial supply and venous drainage of the spleen. The function of the spleen. It is a component of reticuloendothelial system. The important function of the spleen includes, it is the main function, it is host defense and destruction of the abnormally shaped or rigid red blood cells, and phagocytosis of the foreign substances which enters into the blood. It can phagocyte in the spleen and held up there, and it is a great reservoir of the platelet, and erythrocyte production also possible from the spleen, particularly in case of fetal spleen. So all are the various important functions of the spleen. For that reason, the spleen preservation is required whenever possible. To spleen is preserved without removing the whole spleen. So some congenital anomalies. Sometimes the spleen become absent since birth. Is rare, but when it occurs, it is often associated with congenital heart disease. Patients without a spleen are occasionally subject to fetal infection. Accessory spleen or spleneculi. It is another important thing is, normally spleen is present there at the tail of the pancreas, that is normal spleen, but there are some small splenic tissues may remain surrounding the hilum. So these small amount of splenic tissue separated from the normal spleen, these are called the spleneculi or accessory spleen. There are single or multiple accessory spleens which are found near the hilum related to the blood splenic vessels and behind the tail of the pancreas, or in the splenic ligaments, or in the mesocolon. These having a very important functions. They are important because if left behind at splenectomy, after splenectomy, these spleneculi become hyperplasia and enlarge in size, and again takes part to the function of the spleen. So if you remove the spleen for the disease process, that disease process again started because that spleneculi can take role to function of the spleen for that disease. So during removing the spleen, always we examine the surroundings of the hilum of the pancreas, hilum of the kidney, and hilum nearby tissue. There is any accessory spleen present or not. If accessory spleen present, so along with the disease spleen, the accessory spleen must be removed. So they are important because if left behind at splenectomy, they undergo hyperplasia and lead to recurrence of the disorder for which the spleen was removed. So it is a very important thing. Everybody must know the spleneculi. But this is not required for the undergraduate students, particularly their things are asked in the postgraduate students, invariably asked in the Viva examination. The other is the splenic cyst. They consist of the true cyst like Darmard's or mesenchymal inclusion cyst or a false cyst resulting from trauma which contains serous or hemorrhagic fluids. And hematoma, that is normal tissue in haphazardly arranged, which is called the hematoma, rarely found in the spleen, incidentally on post-mortem examinations. Look about another terminology is the wandering spleen. It is a rare congenital anomaly of the spleen caused by the loss or weakening of the ligaments that help to hold the spleen stationary. The spleen is usually fixed in position in the left hypochondrium. It is attached to the ligaments, so more or less fixed in position there. But if the spleen is migrated, go down into the pelvic cavity, then always invariably think it is a wandering spleen. So also known as floating spleen, pelvic spleen, or splenic ptosis. Splenic ptosis, which is not in normal position. It got down. So for that reason, terminology term as a splenic ptosis. Wandering spleen commonly leads to torsion of the spleen. A very important thing is, just like a testis, if it is not in normal position, there is every possibility of torsion. Just is the same mechanism here. Whenever the spleen is not fixed, so whenever the movement of the intestine, so there is a movement or presses over the spleen also and change the position of the individual, and also causing there is some torsion of the pedicle, and spleen become torted and devascularized. The treatment of wandering spleen is splenopexy. That means fix the spleen, but if there is no supply flow after detorsion of the spleen, then splenectomy must be performed. So wandering spleen having a presentation with acute abdomen, and after doing the laparotomy reveals that there is a spleen floating in the pelvic cavity, then you examine it is alive or dead. That means the vascularity is maintained or not. If vascularity is not maintained, then you derotate the torsion. The vascularity is regained, then you fix it. If it is not possible, the vascularity already lost there. So at that cases, you only fix the spleen. Next, another important terminology are hypersplenism. So lot of terminology must be know all the students, because lot of tricky questions in the exam, in the viva, or in the long case, or sometimes the written examination. For that reason, all terms must be know everybody's. So hypersplenism, this is an indefinite term which includes splenic enlargement, that means splenomegaly, and any combination of anemia, leukopenia, thrombocytopenia. So all indicates that they'll decrease the cellular elements of the blood decreases, and compensatory bone marrow hyperplasia, and that all the things are improved if after splenectomy, then the terminology is hypersplenism. That means splenomegaly and hypersplenism is not the same thing. All the splenomegaly does not causing hypersplenism. So rather, splenomegaly is a component of hypersplenism. So now we can evaluate the causes of splenomegaly. The broad headings are infective blood diseases, metabolic, circulatory, non-parasitic cyst, and neoplastic. All of the diseases causing increase the size of the spleen, which is called splenomegaly. Normal spleen spelling is double E. Spleen spelling is double E, but in case of splenomegaly, it is single E. Be remember about it. Sometimes mistakenly written in the paper, splenomegaly, splenectomy, double E. No, it is single E. Be careful about it. Then the infective causes are, most commonly are malaria, chalazer, both the things causing splenomegaly, typhoid and paratyphoid disease, tuberculosis, septicemia, abscess of the spleen, and lastly the schistosomiasis, Egyptian splenomegaly. So these are the infective causes. So that causes are evaluation by your experience, by your location of the patient is. If one patient is situated or staying in the hill tracts area, so in that area they are more prone to develop splenomegaly due to the malaria. So if the patient is a low socioeconomic status, the patient may have a tuberculosis maybe. So the status of the patient and the location of the patient can dictate you the what is the infective cause of the splenomegaly is. So from the status of the patient and the location of the patient can evaluate it for differentiation of the infective cause of the splenomegaly. The blood diseases are idiopathic thrombocytopenic purpura. That means the patient thrombocyte count is declining. So whenever the thrombocyte count is declining, there is a bleeding tendency, there is a patchy red spot throughout the skin and bleeding from the gum, etc. So the cause of the thrombocytopenia, whenever is not evaluated, confirmed, then it is called the idiopathic thrombocytopenic purpura. So whenever there is a platelet count is decreases, so there is more work to the spleen. For that reason, there is a increased splenic in size. But in case of ITP, the splenic size in comparative to other diseases it is not more markedly enlarged in size. In other diseases, is more marked, but in case of ITP, the splenic size is not more markedly enlarged. It is a very important one, and it is very favorite for the laparoscopic surgeons. They can very comfortably do the splenectomy in comparison to the other spleen, because smaller size of the spleen can handle most comfortably for that disease. The other causes are thalassemia, hereditary spherocytosis. That two things are, another one is missing there, hereditary spherocytosis, electrocytosis. Both are the shape of the RBCs are, hereditary spherocytosis are abnormal shape, is more rigid. Whenever it passes the reticuloendothelial system of the spleen, there is a broken of the RBC and there is anemia. The patient needs blood transfusion. So in that case, needs to splenectomy. So whenever the spleen is removed, the longevity of the RBC increases. There is a less transfusion needed in subsequent days. In case of thalassemia, also there is a hypersplenism there to some extent. So they increase the spleen size and remove the spleen to increase the lifespan of the RBC. Whenever there is a more frequent transfusion needed, in case of thalassemia, more frequent needed of blood transfusion, only on that cases go for the splenectomy. Otherwise, no need to go for splenectomy. And another one is leukemia and polycythemia vera. Leukemia is a malignant disorder of the blood malignancy, and polycythemia vera, it is a more RBC is produced, and in that cases there is hypersplenism develops, and that means the function of the spleen is more, so increase in size rarely needed in that case of polycythemia vera, go for splenectomy. But in case of metabolic disease like porphyria, Gaucher's disease, that are the metabolic disorder, and circulatory, like infarct, infective endocarditis. In case of mitral stenosis, the patient having a infective endocarditis, the infective thrombi migrated through the vessels and infarct the occlusion of the vessel, causing blood supply is impaired, the spleen become infarcted. And in that case, splenomegaly also develop, an occasional occlusion of the portal vein. So occlusion of the portal vein causing back pressure, and there is a stasis of the blood, so the spleen become enlarged in size. A non-parasitic cyst like congenital cyst or the acquired cyst, and neoplastic like angioma and Hodgkin lymphoma, that two things may causing some increase the size of the spleen, which is causing splenomegaly. So these all are the causes of splenomegaly. So not only whenever the spleen is enlarged in any size, don't go for surgery. It depends upon what demand the complication of the splenomegaly, what needed to blood transfusion more or not, what amount of mechanical discomfort of the patient, only that cases, or where there is a needed to evaluate or confirm the disease and staging of the disease, only on that cases they go for the surgical intervention. So now we discuss about the traumatic injury of the spleen. Though the spleen is situated in a safeguarded behind the rib cages, but lies inside the abdomen, but it lies behind the rib cage, inside the rib cage. So you don't able to touch the liver from the back directly because the rib cage can support it. Although there is a chance of injury, because whenever there is a more force application over the rib cages, like accidents, there is a trauma, or from directly make a blow directly over the hypochondrium, so it directly hits the spleen and become rupture. Or there may be injury from the back, rupture, that means fracture of the ribs, and that fracture rib also gave injury to the spleen. So splenic rupture should be suspected after any trauma, but particularly if there had been direct injury on the left upper quadrant of the abdomen from any angle. It occurs especially following motor vehicle accident or direct blow by car. If the overlying ribs are fractured, splenic injury should be suspected. Occasionally, a fall without direct trauma to the trunk can rupture the spleen. especially if it is diseased, that means if the diseased spleen is enlarged, so it is more easily can traumatized. For that reason, especially if it is diseased or enlarged, as for example, infectious mononucleosis or malaria. Iatrogenic rupture previously occurred in comparison to the recent more, because in previous surgery they are more hurried, and whenever go for the more hurried, like a total gastrectomy or the left hemicolectomy, needed to mobilize the spleen, colon from the spleen, mobilize the stomach from the spleen at that time, or there is some retractor applying over the abdominal wall, that retractor directly injured the spleen, and that causing rupture spleen, and sometimes needed to remove the spleen. But the diseased spleen is not diseased, it is ruptured due to iatrogenic during another surgical procedure. So it is called the iatrogenic rupture, and sometimes needed to do splenectomy. Ruptured spleen, cases of ruptured spleen may be divided into three groups. The patient succumbs rapidly. So there is a trauma, and directly the patient very rapidly can deteriorate, never recovering from the initial shock due to the massive hemorrhage following tearing of the splenic vessels. That means the injury directly if at the hilum. So the hilar vessels are greatly ruptured, so massive amount of blood loss, the patient go into shock and don't recover, and complete avulsion of the spleen from the splenic. These two causes having at the scenario, at the site of injury, the patient succumb and dead immediately. There is no scope to recovery. And others are, there is initial shock, recovery from shock and signs of a ruptured spleen. That means there is this shock, initial there is some bleeding, the bleeding vessel become thrombosed, or there is clot formation, arrest of hemorrhage to some extent, and you examine and investigate, and there is subsequently diagnosed the patient having a splenic. And some patient may having the injury is not noticed to more markedly, but there is a delayed cases after the initial signs have passed off. The patient feels better and go home, suppose, or the patient keep in a conservative manner in a rural area where the facilities of investigation are not available, and there is a bleeding, and the bleeding is held up by blood clots, and the symptoms of intraabdominal bleeding has been postponed for a variable period of 15 days or more, and late rupture can occur. That means there is subcapsular hematoma. The hematoma increases in size subsequently, the capsule is teared, the bleeding is profuse. Ultimately, the patient dies after the injury of 15 days. For that reason, the presentation is lately in the delayed cases. So what about the symptom? The symptom is abdominal pain, usually severe, but not always. Pain may be felt in the left side of the abdomen under the ribcage. Pain refer to the left shoulder. It is very important thing it is. Pain refer to the left shoulder because the splenic injury, there is a bleeding, irritates the diaphragm, so the phrenic nerve can refer pain to the shoulder. For that is the left shoulder. And abdominal distension commences not immediately. It takes time, about 3 hours after the accident, and is due to the irritative effect of the intraperitoneal blood, which produces peritonism and ileus. The general signs of internal hemorrhage are variable: increasing pallor, increased pulse rate, tachypnea, restlessness. Those are associated with the decreased blood volume. And if there is along with the chest injury, so there is a chest symptom present more marked subsequently. So these are about the general signs. And local signs having a tenderness in the left hypocardium, and abdominal guarding is pronounced in the left hypocardium. The abdominal muscle on the left side more taut in compared to the right side. And there is a sign which is called the Carr sign. That means pain refer to the left shoulder. So if it is a patient is supine, if it is a patient in erect posture or the propped up position, the patient does not having a shoulder pain maybe. So for elicit the pain, the sign can be demonstrated after elevation of the foot of the bed. If the foot of the bed is raised, then the blood clot are more dependent on the side of the diaphragm. So it is due to the blood coming in contact with the undersurface of the diaphragm, the pain being mediated through the efferent and hypersympathetic nerve to the shoulder, which is called the heart sign. And if the patient having a road accident, like a driving seated posture of the driver, so in that cases, or in front side of the car, that or the seat belt, so there is an accident, that seat belt injury may causing some abdominal wall contusion or hematoma formation due to the force impaction of the seat belt injury over the body. And shifting dullness in the flanks is often present. DRA reveals tenderness and sometimes a soft swelling due to blood or clot in the retrovesical pouch. If bleeding is more, then it is trickled down through the left gutter to the pelvic cavity. In that cases may be revealed by DRA examination, some tenderness and soft swelling and in the pelvic cavity. Another one is called the Balance's sign. That means persistent dullness to percussion on the left flank due to coagulated blood, and shifting dullness to percussion on the right flank. And after sometimes, if you change the posture and the percussion is from left to right, then the dullness is shifted to the right. It is due to the liquid blood, fluid blood. That means the blood which clots to some extent become lysis due to the peristalsis of the intestine. So the lysis blood become liquefied and passes throughout the peritoneal cavity. So for that reason, the shifting dullness is present. What about the investigations? Previously examined, in the examination, we ask the question, the answer is ultrasonography. But nowadays, that terminology changes to FAST, F-A-S-T. That means focused abdominal sonography for trauma. F-A-S-T. Focused abdominal sonography for trauma. So it is the main tool of investigation for diagnosis of splenic rupture. So it is a bedside ultrasonography test for trauma patient. Portable ultrasonography machine, you carry it and do it at the scenario, you can easily diagnose the patient may having a ruptured spleen. Spleen can usually be visualized here, and the surrounding hematoma may suggest rupture. And hemoperitoneum can also be assessed. So the ultrasonography can evaluate the size, shape, and what about the surrounding collection or not, everything can assess by ultrasonography, which is called the FAST, focused abdominal sonography for trauma. Previously, we are more accustomed oriented with the plain X-ray abdomen because at that time, the sonography, CT scan, MRI are not available much more in all the area. So we are mostly diagnosed by a non-invasive investigation like a plain X-ray. So it is also takes part role to evaluate the splenic injury. The radiological findings, if you know, you can look and see what are the findings, correlate with these findings, then your assessment there may be a splenic. The radiographic signs of splenic rupture are obliteration of the splenic outline. If you do a good quality plain X-ray abdomen in erect posture, you can evaluate the soft tissue shadow of the spleen. So that soft tissue shadow is not well outlined, and behind the spleen on the medial side there is a psoas muscle shadow there. So if there is hemorrhage there, the psoas shadow is obliterated by collection of the blood there for that reason. So obliteration of the psoas shadow. And another important thing is, on the left side there is a fundus of the stomach. The fundus of the stomach having a fundic gas. That fundic gas is outlined by a smooth outline with the fundus. So on the lateral side, the indentation of the left side of the gastric air bubble may seen in plain X-ray abdomen. So that can dictate you the patient may having a splenic rupture. Or sometimes one or more of the ribs can fracture, can detect it with the X-ray. So fracture of one or more lower ribs of the left side might be present, dictates that the patient may have been associated with splenic injury due to the rupture, rib fracture, the fracture and may rupture, because very close relation with the lower ribs, 9, 10, 11 ribs relation with the spleen. So there is every possibility to injury with this rupture, fracture ribs. And another one is elevation of the left side of the diaphragm. If the diaphragm is more elevated, that there is a collection of the blood inside the abdominal cavity on the underside of the left rim of the diaphragm. For that reason, the spleen, the diaphragm shadow is go up, which dictates the elevation of the left side of the diaphragm. In old edition books having written there, another information is free fluid between gas-filled intestine coils. That can also dictate that the patient may having a splenic rupture and bleeding and free blood in the peritoneal cavity. So these are the plain X-ray findings of the abdomen. Another one is invasive procedure, which is called the DPL, diagnostic peritoneal lavage. Diagnostic peritoneal lavage, which is ATL is given the coelotomy. That means make a small hole in at the umbilicus, put a catheter inside the peritoneal cavity, and after that you take some lavage, abdominal contents with normal saline, push there and collect it and look what is the color of the lavage is. If it is a blood stain, most diagnostic there is a free blood, that means some injury is there. So in the past, it was a mainstay of diagnostic tool for abdominal trauma. When there is no facilities of ultrasonography, etc., CT scan, MRI, at that time, these are the practice. But nowadays, it is very, very rare, easily not done. It provides clue if there is presence of interperitoneal blood or not. So this is called the DPL, diagnostic peritoneal lavage. So look, there is a opening in the umbilicus because this scar is very thin for that reason. Then it is a Foley catheter or catheter. Then there is connected with a set and spirited with a syringe. So these nowadays, all the investigations go behind. This is the final goal to diagnose the severity of the splenic injury. The investigation is CECT, contrast enhanced CT scan. There is two types of CT scan. One is without contrast, another one is with contrast. So for that reason, this is written here, abdominal contrast enhanced CT scan. So though the name is written here is the contrast enhanced CT scan, but for the comparison, before doing infuse the contrast, first do a plain CT scan. So after doing the plain CT, they infuse the contrast and do the CT again. So compare the both things, both contrast and pre-contrast, you can evaluate what is the disease and is there any spillage of dye from the vessel to the exterior or not within the lumen. That can evaluate only by comparison with pre-contrast and after contrast X-ray, CT scan. So that can look the picture of the CT scan. There is this contrast enhanced CT. So within the liver, this is the vascular channel of the liver, which is white appearance there. There is a blood supply within the splenic tissue. This is the normal one. And that part of the spleen is not blood supply there because there is a rupture of the spleen there, cut off the blood supply on that part. And surroundings the normal spleen, there is a rim of there's an isodense area. So this is the bleeding, that means hemorrhage surroundings the spleen. And there is also on the right side, there is a collection there between the diaphragm and the liver. So that free fluid is migrated also on the right side there. So that reason is the hemoperitoneum localized collection around the spleen. It can evaluate it, localized collection there. Hypodense area represent the area of parenchymal disruption. That hypodense area represent, suppose the 1/3 of the spleen is devascularized. Disruption, intraparenchymal hematoma or subcapsular hematoma can evaluate. And contrast blush or extravasation implies that ongoing blood loss and need for urgent intervention. So if there is a big vessel is ruptured, so contrast is expelled out, very more marked and prominent surroundings there, you can easily evaluate that the patient needs urgent intervention. So these are the CT scan findings, contrast enhanced CT scan. And another important thing is, you do a CT scan today of injury, and if you keep the patient in a conservative treatment, you can evaluate the patient after 48 hours or 72 hours or 1 week. Then you can compare the two things, what the findings changes are. You can take decision, keep the patient in conservative treatment or keep the patient go for surgical intervention. That treatment decision can made by one general examination, findings of the patient, and another one is CT findings. So this is a very important investigation for diagnosis of the ruptured spleen. So there is some grading of splenic injury that is graded as American Association for the Surgery of Trauma. That means AST grading. That grading pattern is diagnosed only by the CT scan. And by evaluation of the CT scan, you can decide what grade the lesion is. If it is only one side of the capsule is teared to some extent, laceration, so it is less than 1 centimeter, and there is small subcapsular hematoma less than 10% of the surface area. Compare the whole spleen, only less than 10% surface area is hematoma, and there is small laceration, the laceration size is less than 1 centimeter. It is grade 1. If the laceration size is more than 1 to 3 centimeter, and the subcapsular hematoma is 10 to 50%, then that is grade 2. And if the patient keep conservative and on the day after tomorrow, again do a CT scan, if the hematoma size is more than 50%, then the grading is changes. So you can evaluate, you can decide the patient needs immediate surgical intervention. For that reason, the grading of the splenic injury must know everybody's. And grade 3 is more than 3 centimeter. And subcapsular hematoma is increases more than 50%. Ruptured, another grade 3 is ruptured subcapsular hematoma or parenchymal hematoma. If there is a hematoma, subcapsular hematoma, it becomes ruptured. So in that cases, you can treat the patient as a grade 3 splenic injury. Here it is more than 50% subcapsular hematoma, but the hematoma is intact capsule, no bridging the capsule. So if the bridge the capsule, the blood came out, so there is more bleeding there. For that reason, it is grade 3, but here where there is laceration injury is more than 5 centimeters. But here there is no laceration injury, but there is a subcapsular hematoma, and a subcapsular hematoma become ruptured. So it can treat it as a grade 3. And grade 4-1, so look, the blood supply, there is a segmental artery there. So one of the segmental artery is injured, avulsed. So there is a bleeding. So bleeding from the artery, and that area become infarcted and devascularized, which is more than 25% of the spleen. Then it is treated as a grade 4. And a grade 5 is when there is a shattered spleen, there is multiple lacerations throughout the spleen, the various surfaces. So then it is called a grade 5. So management of splenic injury. There are two types of management. One is non-operative management, and another one is operative management. So non-operative one, in case of hemodynamically stable patients with isolated splenic injury. So in that cases, you observe pulse, BP, temperature, abdominal condition you can assess and observe. And if the vital signs are normal, stable, if needed, go for blood transfusion. and follow-up CT scan again 24 to 48 hours. If there is no deterioration, then you keep the patient in non-operative one. So this is about non-operative management. So the main non-operative management is rest and needed blood transfusion and follow-up the patient with clinical follow-up and investigation follow-up. These are about the management of non-operative management. What about the operative management? The operative management is there is a bleeding from the avulsion or bleeding from the lacerated site or bleeding from the subcapsular hematoma. So your main aim to arrest hemorrhage. So if the subcapsular, there is a avulsion of the pedicle, so in that case you straightforward go for the splenectomy. But if there is a segmental vessel is isolated, avulsed or tear, in that cases that segment is ligated and part is devascularized, become divided and splenectomy done. So stitch is done and arrest hemorrhage. So that is a partial splenectomy can possible to do it to save the spleen to some extent. For that reason, here two terms is written: splenography and splenectomy. Splenography means when there is a laceration is a 3 to 5 centimeter. In that case, it's possible to go for the repair the injury. So save the spleen. Or if there is a needed to splenectomy, go for the splenectomy. But patients with hemodynamic instability and diffuse peritonitis should be taken urgently for laparotomy. Should urgently go for laparotomy. And after doing laparotomy, you can evaluate what treatment is needed. What about the splenography? It is the parenchymal saving surgery of the spleen. The technique is dictated by the magnitude of splenic injury. Superficial hemostatic strategy like fibrin glue, organ beam coagulation, and diathermy. If there is only capsular, some small injury, in that case you can apply and observe if it is arrest hemorrhage or not. If not, then go for the non-absorbable suture repair, mattress suture given. If there is a multiple injury, in that cases you can wrap the splenic tissues with absorbable mesh, that is polygalactin mesh, wrap it, make some stitches over the wrapping so it can act as a reservoir and arrest hemorrhage by giving some compression effect over there and save the spleen subsequently. And resectional debridement. If it is multiple shattered kidney spleen, in that case you can resect and identify the pedicle and ligate it and then resectional debridement done. So these are about the splenography. Look, the spleen is partially splenectomy done. The cut end is with some interposition of the soft gelatin materials giving there. Otherwise, the thread can cut the splenic tissues. So interpose some tissues there. So these are about the splenography. Another important thing nowadays take part role. Now, though it is a controversial issue, it is not established more properly. In future, maybe it may prove that splenic transplantation is also an important function to preserve the splenic function to some extent. That means the shattered spleen or removed spleen converted into multiple slices. That slices are wrapped by omentum, keep it inside the peritoneal cavity. Or some splenic tissue put inside the undersurface of the peritoneum, keep it there, and subsequently you can observe by doing an isotope scan in the nuclear medicine what are the changes develops or not. Some neovascularization is there. To some extent, the splenic function may regain. With that hope, so splenic autotransplantation can done to some extent in other, except in case of ruptured spleen, not in a diseased spleen. In a healthy ruptured spleen can transplanted. Same body spleen is slices made and put over the omentum and transplantation done. This is called autotransplantation. That means autologous splenic transplantation is performed by placing the section of the splenic parenchyma 40 into 40 into 3 millimeter in size into the pouch in the greater mentum. So in case of partial splenectomy, grade 4 or grade 2-5 splenic injury may require partial splenectomy, including the ligation of the lobar artery. So ligation of the lobar artery, then you can excise a part of the spleen. So look at the splenectomy, can be done on open or laparoscopically. In case of ruptured spleen, usually in that cases go for open splenectomy. Other than ruptured spleen, if the splenic size is not more marked, in that cases go for laparoscopic splenectomy. Because the laparoscopic splenectomy, look, there is only a teeny hole, 1, 2, 4 hole can finish your job, and only a small fenestrial incision given in the lower for removing the spleen with a bag by the morcellator or by with a sponge holding forceps, the spleen become broken and piecemeal. So there is an invisible small wound made only in the suprapubic region, that means fenestrial incision. So there is more cosmetic value. For that reason, nowadays it takes upper hand. Other than ruptured spleen, splenectomy is a laparoscopy one. If you do a laparoscopy for open splenectomy, it needs a more long incision in the midline or in the subcostal incision. So in case of emergency one, always go for the quick access, so it is a midline incision. So splenectomy, look, there is a laparoscopy spleen removal. Spleen removal is performed as anesthesia. Laparoscopy removal involves creating or four small ports or holes. Open or laparoscopy spleen removal is performed as anesthesia. Incision of open surgery is either in upper abdomen, into the umbilicus, up the umbilicus or horizontally. Surgery of spleen removal. So open spleen removal, look. Is a partial splenectomy, lower vessels are ligated, then move it out. Then the muscles and skin are closed. Always there keep some drain there. These cases are removed with steroid for 10 days. Open surgery, patient needs to stay 7 to 10 days. There is after splenectomy, there is more chance of lung infection. So possible do for vaccinations previously. So another one is laparoscopic splenectomy. It's a very short video which is done by me in private clinic. The patient having a thalassemia. So divided the harmonic scalpel, spinal ligament divided. The pedicle are ligated with the artery. After that, the spleen put in the retrieval bag. Then throw the bag, it passes down and pull out. So the small fenestrial incision and piecemeally with the sponge holding broken. Then remove it out. And one important thing is, always remember, in case of splenectomy, the pedicle of the hilum of the spleen always ligated with a non-absorbable suture material. It could be a silk, or it could be a PDS or ethibond, etc. Because if you don't ligate properly, if you ligate with the, that means a catgut, there is chance of absorption and chance of splenic pancreatic fistula. So the prevention of the fistula always will ligate the tail of the pancreas with the non-absorbable suture material. And we put the drain after removing the spleen to observe two things. One is for hemorrhage, can assess. Another thing is to assess is there any development of pancreatic fistula. So there is some terminologies. Asplenia. Asplenia means, or absence of spleen, is a vague term which includes spleen removed surgically. Following splenectomy, the patient is asplenia. Or sometimes the spleen become vanished. That vanish is usually developed in case of which term is called the autosplenectomy. Due to the microvascular occlusion in case of sickle cell disease, the vessels are occluded by the sickle cell, in case of sickle cell disease, so that the blood supply is impaired. Ultimately, the spleen become atrophied and become vanished, which is called the autosplenectomy. And sometimes the splenic tissue become atrophied, which is called the celiac, which is common in case of celiac disease. Indication for splenectomy: traumatic, that means rupture after blunt injury to the abdomen, or iatrogenic injury during another procedure, hematological idiopathic thrombocytopenic purpura, hereditary sporocytosis, autoimmune hemolytic anemia, malaria, chalazion, with other visceral like radical gastrectomy, pancreatical pancreatectomy, or total pancreatectomy in that cases, miscellaneous treatment of gastric varices in case of portal hypertension, treatment of splenic artery aneurysm, treatment of splenic cyst or tumor. Complication of splenectomy. That 5 term always know, because repeatedly asked in the exam, in the viva, or in the written, or in the OSPE. So the commonest thing is we deal with the vascular organ. So there is more great vessels there. So there is chance of hemorrhage. Sometimes big spleen causes some adhesion surrounding the diaphragm. So whenever there is a adhesion, there is a neovascularizations. Whenever you remove this big spleen under the diaphragm, there is every possibility of hemorrhage from the side of the diaphragm, adhesion side. So the commonest complication is hemorrhage. Then another thing is gastric dilatation. Whenever a patient having a big spleen there, so that spleen having a pressure effect over the stomach having a pressure effect, so it is not possible to dilate more. But whenever there is a spleen is removed, so there is a possibility of dilatation of the stomach. More space is there. So for that reason, the gastric dilatation is one of the commonest complications after splenectomy. For that reason, put a rice tubes over the stomach, through the esophagus to the stomach to deflate the stomach in the posterior period, early posterior period. So there is a less chance of gastric dilatation. Another one is pancreatic fistula. So pancreatic duct near the tail, if your more tail is excised or ligated, so there is a chance of fistula formation. If you more precisely ligate the pedicle of the pancreatic splenic hilum, so there is a less chance of pancreatic fistula. So if you do the surgery more hurried, so there is a more chance of pancreatic fistula. And another one is whenever you do the surgery, there is hemorrhage, collection there. If it is not functioning with the drain, not remove it out, so there is a chance of infection. That infection may subsequently develop the abscess formation. So there is a written there saprophrenic abscess formation. So in the postpartum period may develop saprophrenic abscess. And lastly, which subsequently the patient may develop overwhelming post-splenectomy infection, because it is the most important organ which can protect the immunity of the patient and engulf the capsulated organisms and remove from the blood, filter blood, purify blood. So that function can not possible because there is no spleen there. So for that reason, there is chance of overwhelming post-splenectomy infection. So sometimes in the OSPE or in the written, that having a short note, overwhelming post-splenectomy infection. It is a short note may present in the written or in the OSPE, sometimes given the question. The answer is it is a rare but rapidly fatal infection occurring in individuals in following removal of the spleen. So after removal of the spleen, there is a chance of infection. This is called the overwhelming post-splenectomy infection. The infections are typically characterized by either meningitis or sepsis and are caused by encapsulated organism. Particularly, the name of the organisms are Streptococcus pneumoniae, Neisseria meningitidis, Haemophilus influenza, Babesia microtia. In some books written there is Escherichia coli also. So that 4 names everybody must know because repeatedly asked in the exam. What are the organism causing the opportunistic infection? You utter the name Streptococcus pneumoniae, Neisseria meningitidis. not meningitis. Meningitis is important thing it is. And Haemophilus influenza and Babesia microtia. So these are the opportunistic infection causing the septicemia. So mechanism, this spleen contains many macrophages that phagocytes and destroy bacteria. In particular, these macrophages are activated when bacteria are bound by immunoglobulin G antibodies, the complement component cascade. These opsonin bind to the surface of the bacteria to facilitate phagocytosis. So that phagocytosis is not possible there because there is no spleen. When the spleen is no longer present, asplenia, that means immunoglobulin G and complement CB are still bound to the bacteria, but they cannot be removed from the blood circulation due to the loss of splenic macrophages. And hence, the bacteria are free to cause infection. Next question, sometime asking the exam, how can you prevent this opportunistic infection in a post-splenectomy infection? That means, suppose a patient having a sickle cell, that means hereditary spherocytosis or ITP or electrocytosis needs to splenectomy. So it is not an emergency situation. So it is an elective surgery needed. In that cases, you can vaccinate the patient preoperatively, so there is a more antibody can form inside the body. The patient is prepared to fighting against the bacteria. So in that case, in case of elective surgery, always takes time to do the vaccination preoperatively. But in case of emergency surgery, they are not too much time to give vaccination. In that cases, you start immediately after operation. So vaccination against Staphylococcus pneumoniae, Haemophilus influenza, and Meningococcus, to prescribe that vaccine preoperatively or just after the operation, emergency operation. Elective, preoperatively start the vaccination. And elective must at least 2 weeks prior, at least 2 weeks. 4 weeks is better. 2 weeks prior to the surgery of elective surgery, you vaccinate the individual. Then, in case of emergency, that means pneumococcal vaccine immediately postoperatively and other 2 weeks after surgery. And pneumococcal vaccine is continued 5 yearly. 5 yearly at the end of the life, up to the end of the life. This is the protocol to give the vaccinations. So by vaccinations, prepare the body with the antibody and kill the bacteria. And other measures not possible to all the vaccine for the patient. So for that reason, we additional to some preventive measures we take by some oral medication, that means some antibiotics. That means penicillin V is recommended for up to 2 years after treatment. At least 2 years must be given in all individual. But another important thing is, in case of children, the age up to the age of 15 years always give, because if the child age of 14 years, if you do the splenectomy, in that cases 15 years only 1 year. So that 1 year does not prevent the child for further prevention of infection. For that reason, in that cases needs at least 2 years, that means up to the age of 16 years. But in case of 5 years of child needed to splenectomy, you can prescribe the antibiotics up to the age of 15 years, not for 2 years. Be careful about it. Clear the conception is. In case of 5 years child, you continue the antibiotic up to the age of 15 years. But in case of child age of 14 years, it must be needed for 2 years after surgery. Go for preventive prophylactic antibiotic prescribed. In other cases, in every cases, you at least 2 years for prophylactic antibiotic for prevention of sepsis. So these are about the ruptured spleen and prophylactic antibiotics and opportunistic infection prevention, name of the infection, etc. Now we can evaluate to some extent of the diseases are the splenic abscess. The abscess collection of the pus in a space lined by pyogenic membrane. Sometime asking the exam, what is abscess? So if you put some pus inside the syringe and take the syringe and go inside any tissue, it does not abscess. So the abscess is collection of pus in a space lined by pyogenic membrane. But disease process, there is a pus formation, a cavity, and that cavity lining by an granulation tissue. Then it is the abscess formation. So abscess can develop anywhere in the body. So spleen also is not an immune organ, so it can develop splenic abscess. So if a splenic embolus is infected, like mitral stenosis, bacterial endocarditis, so that bacterial focus go into the spleen, settle there, and make an abscess formation. And the primary condition does not prove fatal. A splenic abscess may be expected to follow. Other causes of metastatic abscess of the spleen through hematogenous route are typhoid, paratyphoid fever, osteomyelitis, otitis media, peripheral sepsis. So any other causes of bacteremia, from there the bacteria is migrated to the spleen and causes the splenic abscess. So the presentation is very similar with an abscess, chill, rigor, etc. Fever, pain, temperature, etc. The fever, abdominal pain in the left hypocrine, though spleen is lies there, and left shoulder pain if the diaphragm is irritated in that cases, and generalized malaise, dyspeptic symptoms, which mimics with an abscess symptoms. So diagnostic, mainly by ultrasonography and CT scan. The two. The CT scan, if you do a CT scan, that can easily evaluate with the contrast CT, the surroundings of the abscess cavity, there is a more contrast there in comparison to the non-contrast CT. But in case of cyst, there is no enhancement of the CT surrounding capsules of the abscess, cyst. But in case of abscess, the surroundings of the cavity lining, there is more vascularity there, which dictates that the patient may have a splenic abscess. And the content, there is some sedimentation of there. Because the abscess content are the thick fluids there, for there is some sedimentation seen inside the lumen of the abscess cavity. Treatment nowadays, all are minimal invasive. If possible, do it. For there is a percutaneous drainage of the abscess under ultrasound or the CT guided. Drain the abscess, put a pictal catheter there, and drain it out, and pass sand for cultural sensitivity, and treat the patient with antibiotics. The patient becomes cured. But splenectomy is rarely needed. But in case of splenic abscess, the splenectomy is very difficult because there is surrounding adhesion there. More difficult to do the surgery. Complication. Abscess of the upper pole of the spleen may rupture and form a subdiaphragmatic abscess. Look, if it is the upper pole, the rupture and subdiaphragmatic abscess. If it is the lower pole, rupture, it go into the peritoneal cavity and causing diffuse peritonitis. So look, the abscess cavity, the CT scan findings. This is the abscess cavity. So splenic cyst. The cyst having a two variety. One is non-parasitic cyst and another parasitic cyst. So look, in case of non-parasitic cyst, the epithelial lined cyst, the lining is epithelial lining. Epidermoid cyst, most common, mostly asymptomatic, young child, young adults affected, left upper quadrant pain, nausea, vomiting, early satiety. Investigation, CT scan. Complications, infections, bleeding, rupture. A treatment, partial splenectomy. If it is whole spleen is involved, in that case go for total splenectomy. But in case of parasitic cyst, diagnosis by ultrasonography is broadly termed as a hydatitis disease caused by Echinococcus granulosus, mostly asymptomatic, associated with the liver cyst. So treatment, if only spleen involved, then go for the splenectomy. If other organ involved, then you treat, evaluate the whole disease process of the body, then antiparasitic drugs, and subsequently follow up. And if not responded, then go for the surgical treatment. Then, an important thing is splenic pseudocyst. Rarely occurs. There is a lining, there is no lining epithelium. The most common cause is the post-traumatic. Splenectomy is indicated when size more than 10 cm or symptomatic. That means there is a subcapsular hematoma, suppose there. So that subcapsular hematoma become resolved and converted into a simple cyst. Or rupture hematoma, when some blood is exterior to the spleen and localized there and make a cystic collection outside the spleen attached to the spleen that represents a splenic pseudocyst. So thank you very much for elaborate description of splenic diseases. Now the session is open for question and answer session. So, any question, any query? Ask now. Hello? Any question?
Assalamualaikum. Assalamualaikum.
Assalam.
স্যার এফসিসিস একটা কোশ্চেন আছে স্যার, পোস্ট স্প্লেনেক্টমি ভ্যাকসিনেশন ওখানে দেয়া আছে স্যার যে আমরা যদি ভ্যাকসিন না দিই, যদি আমরা প্রবাবলি অ্যান্টিবায়োটিক দিই, ইজ ইট পসিবল টু ম্যানেজ দ্য পেশেন্ট?
Is it possible? Not confirmatory, but if the vaccine is available, so just enters the body, the organism is not capable to produce the disease. So it is better to vaccine the patient. May not be functioning properly. If the patient does not take the drug routinely, so there is a missing, so the blood level of the drug is not maintained. So in that case, there is chance of infection. So if the vaccine, once you give the vaccine, the body is immunized, so the ready antibody is available there to fight against bacteria. For that reason, vaccination is better. And for all organism is not capable to prevention by vaccination. For that reason, prophylactic antibiotic are given there to prevent infection those organisms which are not capable to give by vaccination control. For that reason.
Yes, sir.
Am I clear?
Yes, sir. Thank you, sir.
Any more? So, though spleen is not a big organ, but very important for the exam, thoroughly needs to read ins and outs, everything. Otherwise, you don't able to face in the exam. Because if you don't clear the conception, you don't able to smartly give the answer. So, any more question?
Assalamualaikum, sir.
Assalam.
Sir, why we don't do any blood culture before doing splenectomy, as patient can already have bacteremia?
So, blood culture, all the diseases are not the infective one. So, like a hereditary spherocytosis, the patient is not the infective disease. So, you don't need go for the blood culture. So, blood culture we do whenever you suspect the patient having a fever, infection there. In that case, before surgery, you do the blood culture and look there is any bacteremia, then can diagnosed by blood culture. Only that cases we go for the blood culture. So blood culture is not mandatory to do in all cases of splenectomy before splenectomy.
Thank you, sir.
Okay. Any more? So thank you very much. Thank you for presence hearing. Day after tomorrow, we can discuss about the appendix and its diseases. Okay. Thank you, everybody.
Thank you, sir. Assalamu.